there are some issues, again, that when you're working with patients, you're gonna run into, and this issue of trust is not just an urban myth. It's real. There are objective data to support it, and there's some interesting racial trends. African Americans more often reported low trust than whites. Among African Americans, the quality of the interaction with the health provider is lower in those with low compared to higher trust scores. So trust has something to do with patient satisfaction. Now, racial concordance, meaning that if I'm a black doctor, I've got a black patient. If I'm a white doctor, I have a white patient. Was not linked to low trust in African Americans, but interestingly, it was linked to low trust in whites. That if you had a racial discordant group there with white patient, they linked it more to they had more low trust than if it was racially concordant. And also the site of care, which really drives me crazy in our system. We have a lot of use and abuse of the emergency room, and it's a comedy of errors how that's come about. But that's not a good place to care for chronic diseases. If you have a usual source of care in sites other than a doc's office, that was linked to low trust both in African Americans and whites, but particularly in whites. Now, to me, this is fascinating. Lisa Cooper at Hopkins, they've got enough black physicians there that they can actually have enough of sample size to look at racially concordant patient interactions. And why am I focusing on that? Well, partly getting health literacy and dealing with it and working with people is going to be about communication. Okay, and that's going to be a huge challenge, both verbal, written, and even graphic communication. If you had race concordant ambulatory clinic visits, they actually were a couple of minutes longer and had slower speech in both the patient and the physician. Patient affect was rated as more positive, more satisfying to the patient, and it was more likely to result in the patient saying they'd recommend the doctor to a friend. I think there are a lot of messages here, messages from what our physician, nurse practitioner, PA, workforce looks like. There's messages there that when we are in racially discordant visits, that we probably have a little more work to do. And that shouldn't really bother anyone because that's our job to overcome barriers. I'm in racially discordant situations not infrequently. And I always keep this in the back of my mind. And I try to make sure that the things that they saw here don't interfere with my ability to care for somebody who's not like me. And I don't feel at all put up on or anything like that. There is some evidence linking literacy and health literacy and numeracy to knowledge and health outcomes. And talk a little bit about literacy and health knowledge. And people who are low and marginally literate really just don't understand common health terms. And so things like orally, nerve, malignant, terminal. I bet if I ask people here, just write down their answers, the vast majority of people would get all of these. But you're not going to get that. And so part of the problem is that we sit around and talk in lingo, and I catch myself doing it in patient encounters. And we have to really break things down. We've got a special issue in the state of Michigan and in Wayne County. We got about 30% of our residents are functionally illiterate, and in Detroit it's even higher, it's just under 50%. Okay? So, again, when you have a patient who's non-compliant, really the first thing you need to do instead of blaming the patient is find out why, or do your best to find out why, and then really work on the part that you can do something about. I had a patient this morning, new patient, he's on 7 different blood pressure medicines, and he was just all over the place. Told me one thing, told the PA something else, told the MA something else. And all, it took a lot of time for us to try to work it out. And what happens a lot is that the pace of a doctor's office many times just doesn't allow people to focus on it. This was actually a randomized trial in Pakistan where they took mothers in low-income communities and took trained community health workers and tried to improve over 4 months the immunization rates for DPT hepatitis B vaccine, completing 3 doses, and in their children. And what they found in the intervention group, they got 72% versus 51% in the control group. And what they used were pictorial messages regarding the vaccines. So pictures, graphics, okay? Glycemic control, again, this is very, very important. Diabetes is a horrible disease, absolutely horrible disease. And you're lucky if you have it and you don't have complications with it. The prevalence is going up. The proportion of attaining hemoglobin A1Cs is going up, and control rates in the population despite more physical inactivity and obesity. But between 1999 and 2004, compared to whites, non-Hispanic blacks and Mexican Americans, Hispanics, were a lot less likely to have a hemoglobin A1C less than 7. And still, about half of all diabetics, people with diabetes, did not have a hemoglobin of A1C of less than 7. So again, we've got a problem where it's a problem in everybody. It's more of a problem in 2 race ethnicity groups. But there are also some links to glycemic control and diabetes numeracy. Now, I'm going to caution you. You're looking at a cross-sectional study, and you're very well aware of drawing causality out of cross-sectional studies. But you have to consider all the information that you have. And I actually just had a debate yesterday with Bill Cushman about guidelines and how much evidence they had in them. And actually, the majority of the recommendations in American Heart Association, American College of Cardiology guidelines over the last decade and a half have actually been based on case studies, standards of care, and expert opinion. The level that's the proportion that's all just randomized controlled trial data, multiple trials, is under 20%. Okay. And that's probably not going to change unless people quit making recommendations about things that are important, because trials don't study everything. And I do big trials. I love trials. But I also don't think that randomized controlled trials are going to tell you everything. So this data here suggests that if you consider diabetes-related numeracy in a structural equation model, that the relationship of African American race to poor glycemic control shifts to being insignificant. And what it is suggesting to us is that this diabetes numeracy is actually mediating the relationship between African American race and poor glycemic control. To me, that's good news, because it really gives us something we can potentially target. And African American race in older age were associated with lower levels of diabetes numeracy. Again, like I said, it's a horrible disease. Cholesterol, blood pressure, and the mean distance from the target of LDL less than 100 was about 36 milligrams per deciliter in NHANES 2001-2002. For blood pressure is almost 20 millimeters of mercury systolic. These are conditions, again, that typically you're going to be dealing with in an office setting, where you're going to have to convince patients to take medication along with whatever they'll do with their lifestyle. And for people with diabetes, it doesn't matter what your baseline LDL cholesterol is. You probably ought to be on a statin based on the studies. So how do we improve communications with patients? Well, you can slow down, try to use plain non-medical language, and show or draw pictures. And increasingly, we're starting to actually draw pictures. We haven't done it a lot, but we're starting to do more of it. Try to limit the amount of information you provide and repeat it. And so for me, what I'll do is, when I see a patient and they come in and they've got about 8 things I need to take care of, what I do is, first visit, I basically get on the things that that are the most pressing. And I'm not going to make 8 medication changes. Sometimes it'd be very justified to do. But I'm going to limit what I do. and tell them, yes, here's what I've identified, but we're going to deal with that later. So you have to compartmentalize some of this stuff. Try to do it all at once, you're asking for trouble. You have to create a shame-free environment. People, if they believe that, for example, you figure out they can't read and you're going to think they're dumb or stupid or are going to look down on them or make them feel bad. I mean, nobody that I can't think of the last time somebody told me they can't read. Talking with patients, asking them, do you understand this, that, and the other? So you're going to have to look for tips on that. Okay. Clues that for low literacy, things like, oh, I can't read that, I forgot my glasses. I'll bring this home, I can discuss it with my family. You get these weird-looking intake forms that they're filling out, okay, or trying to fill out. They just don't show up, and they miss tests, or they're chronic noncompliance. Again, why are they noncompliant? Some of it's clearly related to health literacy. Medication review, looking versus reading, or reading stuff that's upside down. So, as I close, what I'd say is that health literacy and numeracy, I think, represent a real important strategy, not for the FORE, but for the delivery of personalized medicine. It's a way to tailor what you do to people. It's not just what the gene jockeys do. I mean, they've been sequencing genes and doing stuff. And for common complex diseases, we still don't know a lot that's really overly helpful in the care of people with chronic diseases. Monogenetic diseases, we've made some great strides. But complex diseases like hypertension, where you got multiple genes affecting 2-3 millimeters of mercury level of pressure in the population, not so good. Assessing health literacy and numeracy is really not commonplace in most clinic settings, healthcare delivery systems. So we're going to have to train the current members of the healthcare team or bring in new members. And I will tell you that there's no doubt that cost and time efficiency issues will be barriers. On the other hand, as we move toward patient-centered medical homes and in the way we're delivering healthcare, we're sort of being really choked to sort of change the way we deliver healthcare. There's a greater focus on health literacy and numeracy is consistent with a more patient-centered, personalized approach to healthcare delivery. So to me, it seems that it's quite logical to adopt proven or even likely effective strategies to improve health literacy and numeracy. However, for those who are researchers, there's definitely a need for intervention research to really help us identify the most efficient means of improving health literacy and numeracy from a cost and time perspective, as well as effectiveness in moving those metrics. And finally, I think the most impactful research studies are going to be those that can show you the link between improved patient outcomes like lower blood pressure, better glycemic control, better patient satisfaction, to improvements in health literacy or numeracy, because of the barriers of time and cost, the people who will need to make these decisions to say we're going to really expand to do this are going to need convincing, okay? And it's not that they're bad people, but they're under a lot of pressure. I'm under pressure, financial pressures to make things work and all. And that's why I kind of like my job, because I keep telling everybody if it was simple, anybody'd do it. It's really challenging, and I'm like the chief problem solver. It's kind of what I do. So I thank you for inviting me, and hope you didn't go to sleep.